the brain is using this information to change the food intake and nutrient handling and energy expenditure. All of this is a dynamic process, and that is changing the adipose tissue size. And when you have a change in adipose tissue size, obviously that gets communicated back by leptin to the energy stores. This is a highly simplified circuit. This is not everything that is going on, but we just want to have a concept of how this regulation is taking place to be able to understand the next few steps. We talk about the factors that modify body weight regulation. I'm not going to be going into a lot of detail, but those of you who practice obesity medicine, you realize that there are a lot of different aspects of lifestyle which are contributing to the body weight regulation. I'm going to start with weight promoting medications, just even though it's not lifestyle, it's a medication. But weight promoting medications are a huge contributor to the regulatory process, and we've all seen patients who gained 10, 15, 20, 30. I've seen patients who gain 150 pounds on a medication. So that is something that is contributing. Nutrient signaling. We hear a lot about how the food environment has changed. It's not simply about the amount of food, but it's also the kind of food has changed significantly. So the ultra processed foods and what is going in there. So that's nutrient signaling. Muscle activation we can use it. We can call it physical activity, but just at a molecular level, the muscle activation has a huge contribution. So does sleep, circadian patterns of eating and sleeping and distribution during the day, as well as chronic stress. So all of these are interacting with the genetics, age, sex, and development phase of the individual to kind of bring about changes in the body fat regulation. And there were some studies that came out around in 2000 which talked about hypothalamic inflammation. Now, what they saw was in rats which were fed high-fat diet, they were developing these inflammatory processes in the hypothalamus. And it is thought that this hypothalamic inflammation is changing the differentiation of the neurons, is changing the transport function around the neurons, impaired leptin signaling, which is really important, obviously, and impaired blood-brain barrier function. So all of these changes, what happens is normally the hypothalamus is kind of depicted here. You have the arcuate nucleus of the hypothalamus and the paraventricular nucleus and the NTS, which is sitting in the brainstem. What is happening is there are AGRP neurons and POMC neurons. They are the yin and yang. As you're getting signals from the outside, including leptin and insulin, all of them are working on the POMC neurons and inhibiting the AGRP neurons. So overall, the tone is higher for the alpha MSH, and that's a person who's able to regulate their weight adequately. And an alpha MSH activates the melanocortin 4 neurons, which kind of contributes to energy balance. But what happens when you have the inflammation? We talked about the leptin resistance, but also a lot of the signals don't get to the right places. So we are talking about these inflammatory blocks that take place, and these inflammatory blocks have been first shown in animals, but there have been signs on MRI that it's present in people. And also, what was interesting is for those who have undergone bariatric surgery, those changes reverse. So there is some evidence that this is important in people. So what happens is when you have the blockage of the signals, then the AGRP axis becomes more active, and then you have changes in the energy balance by increased food intake versus the energy expenditure. This just sets the stage for why medications are important. So medications, at least the newer generation of medications, they are able to bypass some of these inflammatory signals because they work directly on the receptors that are sitting in on the POMC neurons and the AGRP neurons. So just kind of keep that in mind as we talk about the different agents. And as far as the recommendations for anti-obesity medications, all of you probably have already seen this, the different ACE guidelines, AHA, TOS guidelines, and pharmacotherapeutic management guidelines from the Endocrine Society. All of them recommend kind of BMI of greater than or equal to 30 and or a BMI greater than equal to 27 with one or greater obesity-related comorbidity. So in all of this, it says that pharmacotherapy may be considered. They never say that it should be used, which is an interesting wording because when you really think about it, the present use of anti-obesity medications is very low. It's only about nearly half of the patients in the US, which is about 46%, meet the criteria. So you say BMI of 40, sorry, BMI of 30, you have people who are about 42% of the population. But BMI of 27 with comorbidities, that adds another 4% of the population. So you have about 46% in the US that meet the criteria for anti-obesity medications. And what we see is only about 2% of the adults who would qualify get the obesity-related pharmacotherapy. Now, obesity is a chronic disease, and all of us understand. And just to kind of put the same kind of comparison to another chronic disease, which has to be treated long term with pharmacotherapy as lifestyle changes, and does respond to lifestyle changes, the comparison would most closely be diabetes type 2. So in the US, the prevalence of diabetes type 2 is about 9%, but we see that about 86% of the adults with type 2 diabetes will receive pharmacotherapy. And a lot of times they don't wait for lifestyle modifications to kick in before we start the pharmacotherapy. So just something to think about as to how obesity has been treated differentially so far. I'm going to quickly go over these older agents. Excuse me. I won't dwell too much on it, but phentermine, all of you know, it reduces the reuptake of norepinephrine in the synapse. The mean weight loss above the level excess of placebo is about 3.5 to 5%. And again, these studies are from a long time ago, but very short studies, and it's been approved only for a 3-month duration. Orlistat or ALA is a lipase inhibitor. Again, once you subtract the excess of placebo, it's about 3 to 3.5%. It inhibits gastric and pancreatic lipase, and I've yet to see a person that can tolerate this medication. Most of them do very poorly with it because of the malabsorption and of the ingested fat with stool leakage and staining of underwear. It's just it's not very well tolerated. Again, if someone insists on going on something like this, you could use an agent like psyllium or metamucil to reduce the side effects of the malabsorption. Phentermine and topiramate combination leucemia. Among the first generation of medications, you would see that it has the highest efficacy of about 6.6 to 10.8% over placebo. The reason why you have a range of 6.6 to 10.8 is 6.6 in people with diabetes, and I'm going to show you that data, and 10.8 in people without diabetes. So there is that higher end, which is in people without diabetes, and lower end for people with diabetes. And again, this has been approved for long-term use because it's been studied for 2 years. And topiramate is playing an important role here because it has an inhibitory effect on the postsynaptic neuron. So what it does is there is an increase in GABA release, and this GABA release inhibits the inhibitory neurons. So there are neurons which are like in the scaffolding, there are neurons that are inhibiting the POMC neurons. And by using topiramate, you're actually able to inhibit those inhibitory neurons. So it kind of negative becomes a positive. So you have a pretty good response, and it's an off-label use by itself. But when you use it with phentermine in the combination, it's of good value. Naltrexone and bupropion. Naltrexone is an opioid antagonist, and bupropion is a reuptake inhibitor of dopamine and norepinephrine. What bupropion is doing is it's activating the POMC neurons. So that's supposed to be one of the main pathways apart from modulating the reward pathways itself. But naltrexone, it blocks feedback inhibition. Now, beta endorphin is being produced whenever the POMC molecule is being cleaved during the cleavage process. And there's alpha message produced and there's beta endorphin produced. And the beta endorphin is released. So that way that shuts off further production of the alpha MSH from the POMC neuron. So it is thought that by combining these two, you would get some benefit. Again, thinking of something off-label, this should work just as well with anything that would activate a POMC neuron. Setmelanotide, I have to include it here because it is approved for the treatment of obesity, but it is a very specific kind of obesity. It's injectable melanocortin 4 receptor agonist, and it has been shown to increase energy expenditure in rodents and humans with genetic obesity. Not all obesity, but genetic obesity. It does not cause an elevation in blood pressure and heart rate. That is a big one. When you have melanocortin 4 receptor agonists, there's always this concern that you're raising the entire axis, the tone of the entire sympathetic axis, and increasing the blood pressure and heart rate. But this doesn't do that. So it has been FDA approved for these rare genetic disorders. Again, not something that we commonly see, but if you have someone that is a head scratcher, it might be worthwhile doing the testing in clinic. So POMC deficiency, leptin receptor deficiency, PCSK1 deficiency, and body beetle syndrome. These are the approved indications. Body beetle came a little bit later, but these four are definitely approved indications. But there are others that they're trying to figure out if could get approved. The main thing with this medication, firstly, it's exorbitantly expensive. But apart from that, is skin pigmentation. Although I should have bolded it, the injection site reactions are not very common, but skin pigmentation, if anyone gets this medication, they become really dark. They're at least 3 or 4 shades darker than what they are. And that is very upsetting to a lot of patients. So if you ever have to use this, always talk to them about the skin pigmentation first. Now we start coming to the next generation of drugs. It started off with liraglutide, Saxenda, although it's hardly used anymore. Very few people use it, but it's what really kind of got into the GLP-1 for obesity treatment. Again, the mean placebo subtracted weight loss is 4.1% in people with diabetes and 5.7% in people with obesity and no diabetes. The main thing to remember about liraglutide is GLP-1 receptors are widely distributed within the body. They're in multiple tissues. They have a lot of distribution even in the brain. They're in multiple areas of the brain. So sometimes it is this wide distribution which makes it difficult to kind of pinpoint where they're going to go and what effects they would have. But overall, what we've seen so far is it's been around for a long time and has excellent effects on the cardiovascular protection as well as neuroprotection and some effects on the liver and the stomach. There are some negative effects which we will talk about. Lower effects. This is what is interesting. Now, when we're talking about liraglutide or any of the other GLP-1 agonists, the more they enter into the brain, the more effective they are for weight reduction. So the penetration into the brain seems to be really important. So liraglutide at higher doses penetrates better. So the lower dose of liraglutide, when it causes weight reduction, it's mostly a peripheral effect that's going through the vagus or through gastric emptying being slowed. But when you go to the higher doses, it's actually activating the POMC neurons, and again, it indirectly inhibits the NPY neurons. Semaglutide, 2.4 milligram weekly, Wegovy, which it's been around for long enough now that it's not new anymore. But mean weight loss in excess of placebo is 14.6%, and this is in people without diabetes. I'm going to be showing a graph that kind of goes into people with diabetes. But it is almost 3 times as efficacious as GLP-1 based therapy, liraglutide. And this is not thought to be due to more effect at the GLP-1 receptor itself. It's thought to be more to do with with the penetration into the brain and the penetration into different parts of the brain, as well as longer duration of action. is still not very clearly understood, and that's the reason why, as new drugs are being developed, I think we will have a better answer in the future as to which parts of the brain seem to be more important. Initially, we thought it was all about the arcuate nucleus, but we are realizing that the nucleus of the tractus solitarius might be really important. So we just have to figure out, and as we learn more about these drugs and how they're causing weight reduction, we'll get to understand the exact mechanisms of the location of action. The important thing with all of these agents, the GLP-1 agonists, is the GI side effects are most common during the titration. So sometimes just kind of going slow on the titration can make the difference between someone tolerating a drug and not. And I use that all the time, especially when I'm using it for other conditions. And Wegovy cannot be titrated the same way just because there are fixed dose pens, but sometimes when we're using agents like Ozempic, things like that, the titration can be slower, and then you get better side effect profiles because people get used to it and you don't have as much of the nausea and vomiting. With semaglutide, and this is true for every treatment for obesity, not just drugs, lifestyle changes, diets, physical activity, all of them, there is a big distribution. We have a mean weight loss, but there is a lot of distribution between the different kind of categories of weight loss. And as you can see with semaglutide, which at that time was the most potent agent we had, of course, now we have other agents coming up now, which might get approved for obesity. For this is the approved agent, and what you can see is even in this group, about 5% of the people who were taking the drug as prescribed, as they were supposed to in the clinical trial, did not have 5% weight loss. So again, we talk about this as the wonder drug, but there are people who will not respond, and I see them in my practice all the time. So it's something to be aware of and just counsel them around it. On the other hand, you have about three-fourths of the patients who have at least 10% weight loss, which is great, but it starts getting even better. One-third of the patients have about 20% weight loss. And then you start going to one-tenth of the patients have about 30% weight loss. When they did the trials, they did not make these a priori analysis. So again, this is before such claims can be made that one-tenth of the people lose about 30% of the weight, which is equivalent to a bariatric surgery. Excuse me. They need to we need to have more evidence that's designed specifically for looking at that analysis a priori. So now coming to the next chapter, where we got started off with the GLP-1 agonist, and then we have I would say this is probably the third generation of agents, because they are designer molecules that have been created which act on two and more receptors. So several of the common targets for the treatment of metabolic disorders. The first one is GLP-1. GLP-1 is usually as a part of all these treatments because there seems to be the most data about the treatment for diabetes, obesity, NASH, and other metabolic diseases. So it's always been the centerpiece, and then other the effects are added on. So GLP-1 and GIP, GLP-1, GIP and glucagon, GLP-1 and amylin, PYY. So there are multiple different combinations that you can get, and we can look at what that means. Starting first, tirzepatide, which is not approved for the treatment of obesity, but is approved for the treatment of diabetes. You have on the top left, you have the human GLP-1. Let me just make this into a little laser pointer. So you have human GLP-1. And then you have on the right side the human GIP. And as you can see, the tirzepatide is a lot more like the human GIP as far as the structure goes. There's a lot of substitutions and there's a fatty acid side chain. And what it does is its effect seems to be more on the GIP receptor than the GLP-1 receptor. In fact, as compared to things like semaglutide and liraglutide, which have about 1-to-1 ratio of activity, where the same level of activity on the GLP-1 receptor as a human native GLP-1. Tirzepatide has only 1/5 on the human GLP-1 receptor, and more on the human GIP receptor. What that means, we don't entirely know. But prior to the development of this drug, GIP was thought to be nothing like no one ever thought that GIP would be a successful molecule to be used in treating obesity. So we did know that GIP activation was causing fat accumulation, and it was changing bone formation, increasing bone formation. While GLP had all the effects on the food intake and the cardioprotection, etc., and the insulin, glucagon. The insulin release was about the same, but the glucagon effects are in opposite directions. So starting with this, no one ever thought that GIP would be a good agent to have in that dual molecule. But I guess they got really lucky, because what happened next is history. When tirzepatide for treatment of obesity, the results were released last ADA, about exactly 1 year ago. They showed that on placebo there was about 2.4% weight loss, and the tirzepatide 15 milligrams had 22.5% weight loss. So this was a phase 3 study, and it's double-blind RCT. The N was about 2,500 people, and the chance of getting into any one of the groups was the same. And they had a reasonable completion rate, about 86%. Again, you have to remember, when this trial took place, it was during COVID. It was during the peak of COVID. So it was a tough study to conduct for us at UNC, and a lot of sites had the similar issue. But overall, what was interesting with this drug was that about 4% of the people discontinued the drug for an adverse event. So if those who were taking the drug and who were having an adverse event, only 4% reduced to stop the drug. Even though overall adverse events are pretty high, they were not bad enough to stop the drug for a lot of patients. And the differential between the placebo and the tirzepatide 15 milligrams was about 20.1%. At this point, for those of you who have been looking at these results previously, you probably already know, but placebo is not truly placebo. Placebo, as well as the tirzepatide groups, they both get lifestyle intervention during this trial. They have a dietitian who counsels them. They are counseled on increasing physical activity. It's not very intensive, but there is counseling that's taking place during the entire duration of the trial. So difference between placebo versus the tirzepatide 15 was about 20% weight reduction. It just got presented at ADA. I think it was like 3 days ago, and it was simultaneously published in NEJM, where this is the results of the first triple G agonist. It's called retatrutide. Even the company people just call it Reta. It's just too long to say it right. But it has all three Gs, which is GLP-1, GIP, and glucagon. Again, it is much more affinity to the GIP receptors than the GLP-1 or the GIP receptors. So this was a phase 2 dose finding study. Again, it's way off before we can get it into phase 3 trials, and if they market it for the treatment. Double-blinded RCT, and there were 338 adults. As you can see in the placebo group, again, the placebo did receive lifestyle intervention. It was about 2.1% weight loss. But you can see just over a period of 48 weeks, the higher doses, 8 milligrams and 12 milligrams, got about 24% weight loss. Now we're talking about 48 weeks, and as you can see, the dark lines, they're still sloping downwards. So they haven't stabilized yet. Based on based on this slope, it could probably land up somewhere at 27-28% weight reduction. What is also impressive and you can look this up in the paper itself, is women had a much higher response rate as far as weight reduction. Men, it was around 20%, but women had about 28% weight loss on average at 48 weeks. And those who were heavier tended to have more weight reduction. So it's again interesting data. We have to see what comes out in the phase 3 study. This is again something that just got presented at the ADA, and it is about oral semaglutide, 50 milligrams. So semaglutide, as you know, 14 milligrams has been approved for the treatment of diabetes. And in clinical practice, it works out to be equivalent to about 1 milligram of semaglutide for weight reduction. I'm not saying this for the hemoglobin A1C reduction, but for weight reduction, is about equivalent to 1 milligram. But then with the higher dose of semaglutide and a little bit of a change in formulation, you see that over a year's time, after the titration and all is done, the weight reduction was about 17.4%. So it's very close to what they got with the injectable semaglutide 2.4. And again, the randomization was 1:1, and the N was relatively small because they already knew that the drug was quite effective for the treatment in the injectable form. So N was only about 670 people. Again, hot off the press, this is a study which was published in NEJM. At the same time, it was presented at ADA. This is one of the new molecules. So we were talking about oral semaglutide, which is a peptide. So peptides are very finicky because of the carrier molecule and all. They have to be ingested in a specific way. And when you tell people to take it, you're asking them to take it on an empty stomach and then just drink it with 4 ounces of water and no moving around too much, no exercise. And there are all these things because it goes the capsule goes down and attaches to the gastric mucosa, and then after the attachment it releases the peptides into the bloodstream. So this is a very finicky process, so therefore you cannot eat and take the medication because it won't get absorbed. But that's where the new generation of small molecule oral GLP-1 receptor agonists come in. These are small molecules, so they're not peptides. They're going to be easier to make. So hopefully we won't have the kind of problems that we have with getting any of the GLP-1 agents. So it should be easier to manufacture. So it is going to be a good option if it becomes available and if it gets developed. So this was a phase 2 dose finding study, again a small size, and the randomization, they were trying to figure out the higher doses, whether they need to titrate it a little bit differently. That's why you see the randomization schedule. And there was 12 milligrams, 24, 36, and 45. 36 and 45 had 2 groups where they used different types of titration. And this titration was more to get better tolerability. And what they did see is a period of 36 weeks, again, relatively short. You could see that there is quite a bit of response in the higher dose, the 36 and the 45 milligram doses, going to about 14 to 15% body weight loss, while the placebo is only about 2.3%. Again, the beauty of molecules like this is the easy access, and it's once a day, and you don't have to worry about what you're going to eat it with. The next is amylin receptor agonists. So amylin receptor agonists have been used in the past. The main one to kind of note is pramlintide, which has been used for diabetes. But cagrilintide is the new one that was just kind of it was they were exploring for the use of treatment of obesity, and it is a non-selective agonist. It works on both amylin and calcitonin receptors. It has a long half-life. That's why it can be used once a week, just like some of the other agents, and it's an injectable. Again, it's a peptide. It has to be an injectable in most cases. There's pretty strong weight loss in rodents and humans. In the phase 2 study, it had shown about 11% weight loss at 26 weeks. So what happened is um, they started thinking of combining it with the semaglutide, and that's what the CagriSema has come about. It's right now in phase 3 trials. There was a trial that was reported during Obesity Week for people in diabetes, but I don't have the data. I'm not showing the data here because I'm trying to show mostly obesity only data for you to be able to compare. This was an earlier reported trial with a phase 1B trial, so it was very early. And as you can see, so what you see on top here is the cagrilintide target dose, and and you have the different doses: 0.16, 0.3, 0.6, 1.2, 2.4. And then this group did not have any CagriSema, that is 0. So, so all of these people got semaglutide 2.4. So they were getting semaglutide. For this group, they got only semaglutide. They didn't get the cagrilintide. And as you can see, semaglutide only was giving about 10% weight loss, and CagriSema gave about 17% weight loss. And we are seeing some good results in what was also disclosed at ADA a couple of days ago. Overall, with the higher doses of 1.2 milligrams or greater, there was about 15 to 17% weight loss. And again, this was a 20-week intervention, very short intervention, giving some impressive results. So there are other potential drugs in the pipeline. What you will, if you're kind of looking at this, you will see that the last four of them, they're all combined GLP-1 receptor and glucagon receptor agonists. It was initially thought that glucagon receptor agonism is the best way to do it because glucagon receptor agonists, especially in animals, cause increased energy expenditure. So that's why they developed a lot of these molecules. And they're not looking very much into the GIP until they saw some benefit from that terzipatide. I want to bring your attention to the highlighted one, which is Amgen. They did a phase 1 study. What is interesting about this molecule, it is a GLP-1 receptor agonist and a GIP receptor antagonist. So you have tirzepatide, which is a GIP receptor agonist and a GLP-1 receptor agonist. But here you have GLP-1 agonist and GIP receptor antagonist. What is interesting is it's also once a month. It's not a day. It's not a weekly injection. And the phase 1 study showed really impressive results. So we'll see how that development takes place. But there was about a 15% weight loss over a period of just 3 months. So again, we would love to see what's happening, but I think this has a lot of promise because less frequent and also seems to seems to have a very powerful effect at a very short period of time. Again, we have to remember that the safety is a different issue that we have to still figure out for these agents, and that's why we need the phase 3 trials, which have large numbers of patients. So overall, just kind of like looking at the snapshot of where we are, the placebo-subtracted weight loss in anti-obesity medications, and I put all of them here. These are for people without diabetes and obesity only. You can see that in 1959, when phentermine came out, it was about like average about 5%. Again, we don't have long-term one-year weight losses, but this is what we have from the early studies. Orlistat, again, once you subtract the placebo, you have 2.6% weight loss. And phentermine topiramate extended release, you have 8.8% weight loss above the placebo. Bupropion and naltrexone is 5, liraglutide is 5.3. And what you can see here is this red line. This red line is the cutoff for what the FDA says is effective for weight reduction, and that's 5% weight loss. So you need to have an average of 5% weight loss to say that you're effective for the treatment of obesity, and the 5% is along with lifestyle intervention. What you see on that, the green line on top, which is the 30%, that is what you see with bariatric surgery. On average, sleeve gastrectomy, gastric bypass, It's around 30 to 35%, but you can say safely 30% would cover most of sleeve gastrectomy surgeries. And you can see that semaglutide starts jumping up. It kind of covers a lot of that. It's almost twice as effective as phentermine topiramate and about three times as effective as liraglutide. And then we have tirzepatide, which is not yet approved, hopefully later this year or 2024, but that's a 20% weight loss. And as you can see, we're getting closer and closer. And then finally, this is the number that you're seeing is cagrilintide. It got named. It was initially named AM833, but then got cagrilintide in its name. And the expected weight loss that at 1 year in people without diabetes is going to be like 25%. Now, why are we trying to kind of really start? Why are we looking for things which are more and more efficacious? Why not stop at 20 or 25? Because you have a lot of benefit already. Okay, what's going on here? Okay, I'm sorry, I don't know what I pressed. Oops. Can someone help with this? I'm not sure what happened.
Advance the screen.
Just
Lower left-hand corner, you should see the options.
so I'm saying starting subtitles. Is that what the screen you're seeing?
Yeah, it's not doing anything though.
I want to take that off, and I'm not able to see how to get off. Oh, there's another way to get. Okay, there is.
If you okay.
Excellent. Yeah, it just stopped advancing. Sorry. So we start kind of trying to play it out as efficacy versus invasiveness of present and future obesity therapy. So if you want to kind of go through this, first let's kind of plot most of the therapies that we have on this percentage weight loss at 1 year versus invasiveness. The more invasive they get, they have to be more efficacious for it to be a valuable treatment. But the best would be if you look at that line, just pay attention to the line. Anything that goes above the line is really with low invasiveness, they're giving us more benefit. So first place is the lifestyle and behavioral therapies, especially the intensive behavioral lifestyle changes. There is more weight reduction and the invasiveness is relatively low. I'm not talking about the cost or the longevity in this case, but we're just talking about 1 year weight losses. So you're seeing that lifestyle and behavioral therapy are above the line, and that's really that's great to see. Then you have bariatric surgeries. The one that's right on the top is a duodenal switch. And the one that's right at the bottom is something like a sleeve gastrectomy. So you're beginning to see the pattern with the aggressiveness and the invasiveness of the therapy versus what kind of results it's producing. The previous generation of anti-obesity therapies are sitting at the bottom. They don't cross that line. And that is important to remember. There's more invasiveness with side effects, but we were not getting the kind of efficacy that we really want to get. Endoscopic therapies are not much better. They're just a little bit better than the previous generation anti-obesity medications, and really not cost effective because a lot of insurances don't cover it. There might be a few that might be willing to pay out of pocket, but generally they're not as efficacious for the invasiveness. But the newer generation of anti-obesity therapies, as you can see, is like the first purple dot right here is semaglutide. That's right on the line, and that would be tirzepatide. That would be cagrisema, and you're seeing that the invasiveness doesn't seem to be going up because they are just as well tolerated, but the efficacy is much higher. So this is exactly what we want to see. We want to see less invasive therapies which are getting better with weight reduction. And the reason why we need more of these and much more efficacy is because of this reason. We know that we keep seeing this all the time, that anti-obesity medications don't seem to work as well in people with type 2 diabetes. And this is just an example I'd mentioned it's phentermine topiramate. You have 10.8% weight loss if they don't have diabetes, and if you have diabetes, the placebo subtracted weight loss is 6.7. So it's almost a 30 to 40% drop. Same thing with naltrexone bupropion, same thing with liraglutide, same thing with semaglutide. Now, semaglutide is a much larger drop. As you can see, it's from 14.6% at the 2.4 milligram dose. It drops to 7.5% once you do the placebo subtraction. Again, quite disappointing when you're treating people with diabetes. So now the tirzepatide, the 12.4 was just reported, and that's the one that was just published in the Lancet, because that was results that came out at the ADA. So it was 20.1% without diabetes, but when you have diabetes and obesity, it's lesser, but still a lot better than anything else we have. Almost 1.5 times as efficacious as semaglutide. And with the newer agents, we've got to see the reported weight reduction with the CagriSema for people with diabetes seems to be around 15%. So again, exciting times ahead for people with and without diabetes. Weight loss with semaglutide and intensive lifestyle intervention was looked at in a different study where initially I had mentioned that they were looking at only basic lifestyle interventions. But if you start looking at more intensive lifestyle interventions, you have to look at the step 3 study. And what you see out here is when the intensive lifestyle intervention was done in the placebo group, there was a 6.2% weight loss uh, after the intervention was conducted. And with along with the same intensive lifestyle intervention, if the semaglutide was given, it was 17.6% weight loss. And as you can see, the follow-up is good and the treatment adherence was reasonably good. Relatively small study because this was not the primary pivotal study. But then you start comparing it to the pivotal study, which I placed right here, right next to it, which is a step 1 study. And as you can see, the placebo weight loss was only 2.4%, right? So intensive lifestyle intervention increased the weight loss in the placebo group. So whenever you don't get a medication, they were doing really well. But once the medication was put on board, the difference was only like 0.7% between the intensive lifestyle intervention and without intensive lifestyle intervention. So that makes us think, is that even necessary? So let's look at the other data that has been around in this field. Sometimes it seems to freeze up. Okay, so this is a study that was published by Dr. Tom Warden from UPenn, who did a lot of the lifestyle interventions and lifestyle modification studies. And this was an early drug, sibutramine, which is no more in the market, but just goes to show that in this, the study that he did, the sibutramine alone versus the combined therapy, there was a big difference. So by just giving the sibutramine alone, he didn't achieve much. But when he did an intensive lifestyle intervention along with the sibutramine, the combined weight loss was much more. So what exactly is happening here? Why is it that intensive lifestyle intervention is not working the same way as it worked for the earlier generation? So it could be that as you know, when you see these patients, they have substantial appetite changes when you start any of these newer drugs. And with this substantial appetite changes with, for example, with semaglutide, the typical intensive lifestyle interventions where you're trying to base it on reducing calories, it does not really add much to the outcome. For example, in the trials when we were doing with tirzepatide or when we were doing with semaglutide, we were watching the calorie intakes and we were measuring everything, and it people just could not eat enough in a lot of cases. They could not meet what we were asking them to eat. We were asking them to increase the calorie intakes, but they were just not able to do it because they felt sick when they ate too much. Basically, it looks like they're not able to eat as much, and if you're going to try to focus on just amount of food they're eating and then trying to work on that, it's not going to really add much to the outcome. So we have to start thinking of how do we use other lifestyle interventions in these groups. So once you start using newer anti-obesity medications, the appetite suppression is so much that you want to kind of really think of other interventions and not just focus on how much they're eating. One of the things to do is change dietary content, resistance training. All these things would be appropriate. But also, we have to keep something that's really important in mind. The newer agents which have been in the pipeline, we are expecting weight reductions that could reach up to 30% in at 1 year, and this is going to be in the future, not right now, but in 5 years or so. So if they're going to have 30% weight loss at 1 year, that is just like bariatric surgery. So we need to start thinking of like adequate nutrition for them more than just trying to get more weight off. So if you think of adequate nutrition, we are thinking of it just like treating them like bariatric surgery. So nutrition in bariatric surgery is not about helping them lose more weight. It's about making sure that they don't get sick when they're going through the weight loss process. So we have to start thinking in the same lines once we start reaching these huge numbers for weight reduction. Um, the other thing to also remember with all of these agents, and patients keep asking this all the time, is that there is weight regain after withdrawal of semaglutide, or any of the more potent agents. And when the studies were when the study was looked at it was published in 2022, you see that after the end of the trial, when the people went off the medication, they had about 66% weight regain. Why didn't they regain all the weight? I can tell you, one of my patients, I put the patient on off-label semaglutide because she was desperate and they were so hungry and desperate and crying. So people, when they go to the doctors find a way to get some other agents on board. So that kept them from regaining all the weight back. But just goes to show that it is really important to keep that in mind. And no matter how much of weight they lose initially, the weight regain is always going to be there. So something to really keep in mind. And again, we have to reiterate when we're talking to them about obesity being a chronic disease, and ongoing treatment is required to maintain improvements in the weight and health. So comorbidity improvement for weight loss, you can see them on the left side: physical function, type 2 diabetes prevention, glycemic control, hypertension, and you see what ranges of weight loss you need to be able to get benefits there. So if you have like 5% weight loss, you're going to be getting some benefits. They're going to start. But then you have a higher, like 7 to 8, 10% weight loss with some of the older anti-obesity agents. You're going to see more benefits, but you really have not maximized the benefits. Once you start seeing 15% or more, you know that you start maximizing benefits for physical function, type 2 diabetes prevention, obstructive sleep apnea, etc. So just something to think about, that there are sweet spots to be able to achieve. And it's not always about more is better. Sometimes it is, like for NASH, the more weight loss, the better. But you can get some of the other conditions to improve to the maximum extent. I'm going to summarize the medication part of it. We see that medications are progressively getting more efficacious, and lifestyle interventions may not be necessary in the same way as far as the intensity goes in individuals who are on the newer generation of agents. We have to really change our focus into getting better weight loss but avoiding the consequences with nutritional issues such as muscle loss or dehydration, etc. 15 to 20% of weight loss seems to be a soft spot with the newer medications, and appears to have a sweet spot for quality of life and comorbidity improvement, etc. And this level of efficacy has been achieved with mild to moderate side effects without anesthesia, no major abdominal surgery or operation, risk of long-term nutrient code deficiencies, etc. So that the last sentence, obviously, when you read it, is like, okay, so what's going to happen to bariatric surgery? And that's, I'm sure, is on everyone's minds. But I would say that bariatric surgery is not going to go anywhere. It's going to continue to play its role because of the cost. The cost of bariatric surgery is about $20,000 to $30,000 total for the procedure. Yes, there's the doctor visits and all are extra, but this medication itself is going to be costing 11 to 16,000 annually, and it depends on which one we are going to be using, off-label, on-label, whatever. So there's also the durability of outcomes. Bariatric surgery, you have 20-year outcomes with prospective control trials, 10-year outcomes with randomized control trials. With new medications, you have only about 2 years of data right now, and we'll get more when the select study reports. We'll probably have up to 4 to 5 years data with cardiovascular risk. But again, these are all things you have to think of. And also the cardiorenal outcomes with bariatric surgery in type 2 diabetes. You have so much more that that data that's already there with the number of surgeries that have happened, and kind of just been looking at all of this and how it improves multiple comorbidities and long-term hard outcomes. So where is the role? The role is after Roux-en-Y gastric bypass, we know that weight loss is quite variable. And this is a paper that came out of my previous lab in 2013. And you can see this distribution of weight around about 40% weight loss with Roux-en-Y gastric bypass. Again, it was a homogeneous white population, but you see that there's a lot of biological variability, and it doesn't matter what the BMI is. It's not really determined by BMI. And when you have some of these people on the left side who don't lose much weight, right here, they're losing only about 9% of their body weight, or about 15-20% of their body weight. They would be probably good candidates for this kind of treatment versus having revision. Revision is also an option, but these patients could be seriously considered because they've already had bariatric surgery. So overall, when I think about obesity treatment algorithm and in the medical program that we build, we want to have self-directed lifestyle change, and we want to have professionally directed lifestyle change with the dietitians and people who are specifically instructing patients on physical activity, sleep, stress. We want to have anti-obesity medications, weight loss surgery, and post-surgical combinations available. And it all depends on the severity of the obesity where we start. So you could have entry into self-directed lifestyle change, a professionally directed lifestyle change. You could have entry into the anti-obesity medications along with the lifestyle changes. You can think of weight loss surgery along with the lifestyle changes. Or if they've had surgery and they fail it, then you can go to post bariatric combinations. So basically, overall conclusion is pharmacotherapy has traditionally been greatly underutilized for the treatment of obesity, and anti-obesity medications effectiveness is coming from addressing disrupted biological pathways that are causing, promoting, and maintaining obesity. And the newer agents are better going to cover the efficacy gap between lifestyle interventions, which give about 4 to 7% weight loss, and bariatric surgery that gives about 30 to 35% weight loss. But now we're moving into an age where medications, weight reduction, what medications which are not very effective in the past now are getting so effective that they may go beyond the efficacy of bariatric surgery at 1 year time point at least. And we need to start thinking of managing the nutrition status of these individuals the way we manage bariatric surgery patients. This is the potential to change the landscape of obesity and associated comorbidity management. And the major barriers to adoption are availability, cost of agents, and need for long-term use. So this is going to be the big one, and insurance coverage, all those become a part of it. But before we forget anything else, we need more data on durable and hard outcomes like cardiovascular outcomes, which we will hopefully get within the next year or two with the SELECT study. Post-bariatric surgical use of anti-obesity medications provides a viable option for the patients who are not responding, and using an overarching strategy where all treatments are being used in combination will ultimately produce the best outcomes for patients. But the bottom line is obesity medicine is entering a golden age. And if you're interested in this field, now's a good time to jump in. If you're already doing it, congratulations, you're going to be on the fast track. So that brings me to the end of my presentation. I'm sorry I went over a little bit, but I'm happy to take questions if anyone has things to talk about.
Thank you, Sriram. It was wonderful. Gave us a lot to think about. If any of you have questions, you can either enter them in the chat box or you can unmute yourself and ask the questions. While you're thinking about it, I wanted to ask one question. What do you think about tolerance? Let's say, the higher dose semaglutide obviously has been around only for a shorter period of time. Many of them, what can I tell my patients if the efficacy will last 2 to 3 years from now at the same rate? Are we going to be adding another medication? Are we switching from semaglutide? I'm glad to hear CagriSema. I think when I looked at some of the data, it didn't look as efficacious. I guess the newer ones are showing that better. Your thoughts on tolerance to these medications?
So, do you want me to answer the CagriSema also, or just the other one?
Yeah, both. I mean, it's just a question of, do we need to keep increasing the dose and trying to find more and more drugs for our patients because they no longer work?
So, the question of tolerance is an excellent one, and it was more, it really came up with phentermine for the first time because of the change in the way the receptors seem to be headed in the brain, and using it for long periods of time, this tolerance was developing even though the doses were not changed. But as far as semaglutide goes, the step, I keep forgetting which step is what, but I think step 5 looked at 2 years data. And the difference between the one year weight loss and 2 year weight loss was negligible. It was not like in the past, liraglutide had shown slow weight regain. But that was one of the concerns I had. It's like, oh, wow, at the end of 4 years, are they going to gain all their weight back? And no, semaglutide doesn't seem to have the same amount of weight regain. But again, I think the SELECT study, where they're expected to be on it longer, will hopefully tell us a little bit more, although it's a cardiovascular outcome trial. And it's based on the number of events. It should have run for a total of about 4 to 5 years, but by the time it's done, and that might hopefully tell us a little bit more about the longer term use of these drugs.
We have a couple of questions in the chat box. Dr. Morselli says, thank you for this excellent presentation. What could be the reason for less weight loss in patients with diabetes?
That is the question I've gotten every time I've given this talk, and I wish I knew this. Like, I've been trying to put together different ways of firstly, I would say, like, it's spot on. We know about all of this, and there are some treatments which don't do this. For example, if you look at all the lifestyle interventions for step 1 and step 2, the step 2 lifestyle interventions, which for diabetes, there was more weight loss. So the step 1, which is without diabetes, gave 2.3% weight loss, but with the lifestyle interventions for diabetes gave 3.3% weight loss. So the lifestyle interventions seem to be doing better, but these drugs don't seem to be doing as well. And I would be lying if I said that I knew exactly why. I could give all kinds of hypotheses, but I just don't know. And I don't think anyone really knows why that is happening. Everyone just waves their hand and says, oh, it's always less efficacious in diabetes. But I don't think that's the correct interpretation, because even this I forget that the gel, hydrogel. I'm forgetting the name of the hydrogel, which some people use. It's not very commonly used, but you take it with meals and kind of fills up your stomach. Gelesis. The gelesis, interestingly, causes more weight loss in people with diabetes. So it doesn't cause as much of weight loss in people without diabetes, and it has more benefits for people with diabetes. So it's not a blanket difference. It seems to be something very specific to the mechanisms by which some of these are acting versus how the drugs are acting. Again, your guess is as good as mine. If you have any thoughts, I would love to hear it.
I always rationalize as resistance. Patients with diabetes at one point, GLP-1 either resistance or deficiency was considered the reason for diabetes. I mean, again, it's all pure speculation on my part, but and we have one more question. Do you foresee the price of these medications dropping anytime soon with competition?
I do think that it will drop. It will drop because of different reasons. The thing is, one of them is that liraglutide was supposed to go off patent soon, and and that would be an easier way of getting that. But I think the problem seems to be it's actually not that the drug is difficult to make or is so hard to make. It is difficult to make. The peptides are harder to manufacture. That's the reason why the world's largest manufacturer of pharmaceuticals hasn't figured out how to manufacture peptides. That's India. They have not figured out how to manufacture peptides. Everything gets manufactured in Europe and goes there, but they manufacture everything else. For example, SGLT2 inhibitor costs about $400 out here. In India, it's dirt cheap because they're able to make it. And it is, and I'm very hopeful that once the small molecules start kind of becoming commercialized, those will be easier to manufacture. That's one. Second thing is, as long as this huge kind of deficit is there as far as the needs and the demand is there and the deficit in production is there, I don't think we'll be able to get to a good price. But once the market is flush with these agents, then we might see more of these discounts outside. The the thing to remember is the reason why we have these high prices are because of PBMs. Those are the main reasons why we are PBMs. It's all about PBMs, the pharmacy benefit managers, and I just realized what that is and why they're doing this. They make them hike the manufacturer hike the prices so that they can have a larger kind of margin for themselves. So the PBMs are the ones who force them to kind of have a high price. So unless the whole thing gets overhauled, we can't really see an improvement because most of you already know this, but Britain gets Wegovy for £100 a month. So and we have to pay $1,500, both developed countries. So it's about the broken system and not about the drug itself. So when will the PBMs get fixed? I don't know. It'll probably need an act of Congress, but at least the other things might start working where we have more generics coming out. If liraglutide becomes generic, that might be an option where that will be used more commonly. Once the small molecule GLP-1 receptor agonists come out, they might be able to figure out how to make it in India, and then you have a lot more of that access. Again, I don't know if every market will have the same access, but across the world, there'll be improved access.
Thank you. I don't think we have any other questions, but this was a very good thought-provoking talk. Thank you. And thank you everyone for attending.
Again, thank you very much for having me here.
Bye everyone.